Simar, Rajan Singh from PGI Chandigarh to talk to us about the Electro Oculogram. Again, a very important technique to understand the function of the outermost layer of the retina, that's the retinal pigment epithelium, which while we do study with autofluorescence, but as we saw in different examples, the structure can look normal, where the function will be abnormal. And how do we check for these functions in the presence of either a normal looking eye or an abnormal looking eye? So electrophysiology unlocks a lot of mysteries of patients seeing different from what the doctor is seeing. And that is the beauty of it. And of course, for myself, it's the tool that I'm going to use when I have Parkinsonism. I can't operate. I can still, stimulate my brain cells to think of what the patient has by doing this beautiful technique of electrophysiology, which I think will stand to me even when I will not, be operating. So I think everybody who works with patients, whether it's general ophthalmology or retina specialist or pediatric ophthalmologist, they should have a pretty good idea of the electrophysiology, because that's what the eye sees. And now we have handheld tools. There will be a DSTC. I'm running it on Saturday, and somebody else is running it on tomorrow in the diagnostic center. And of course, there are all the companies displaying their electrophysiology equipment. Previously, we had a lot of problems of getting them to India, but now a lot of companies are selling, and I think there are a lot of centers which are doing electrophysiology. So it's good to learn these techniques, even if you're not doing, but to understand what the test means, because the patient will come with the report, and then you should not look lost. And if you don't know, just say that okay, there is somebody else who can interpret this report for you. But we should know where these things work. And meanwhile, I think there's some glitch. If there are any immediate questions, we can take questions while we have the talk. Anybody wants to ask any questions? Go ahead.
So I want to ask, if you have a normal pattern ERG and a normal multifocal ERG, that means the retina is functioning fine. Because I'll just the question is, I have a 20-year-old with bilateral temporal parallel 6/120 vision. Now I thought it is LHON, but when you get all those testing and when I get the genetic testing done, it comes to be COD. Father is positive for COD, it's autosomal dominant, heterozygous, but the electrophysiology is absolutely normal.
So how old is the child?
20.
Yeah, so COD, it comes in the second decade of life. So if you have multifocal ERG may not be normal actually, especially if the vision is 20/200, you said, right?
Yeah.
So with that kind of fixation, maybe the fixation is not proper or something. Multifocal ERG should be down. Pattern ERG, you have to see the field. If it's a smaller field that you're doing, you may find that it is normal. But actually, with that kind of vision, pattern ERG should be low. It should not be normal.
So both are
and I think Praveen has talked about the artifacts that
it
sometimes
must be
the multifocal ERG can look normal, but you have to look at the waveforms. That is very important. If you just look at the signals, sometimes there will be huge signals, but these are all artifactual. So whenever we interpret electrophysiology, just like we interpret field, first is to see the reliability and to see that each waveform is proper. So the signal to noise ratio has to be looked for. And then only
a vision of 20/200 and normal pattern ERG and multifocal. In fact, I would say pattern ERG should be non-recordable.
Yeah, but if it is so, that means that the patient has serious optic nerve disease. If your macula is looking normal, so everything is looking normal.
And
OCT
COD means
okay.
full field ERG. How was the full field ERG?
It's normal. Then we got the multifocal after that.
Yeah, so if all these tests are normal, then you have to really think that is there genotype-phenotype correlation. Then you need to look at the optic nerve function.
That's right. So that's what I wanted to know regarding the ERG.
Yeah, so then even the genetics can be false positive, false negative. So the whole story has to be put together. What's the color vision, when it starts, what's the family history. And as we know, the diseases don't follow books. So it's up to the clinician to bring the whole story together and say what is happening to this patient. And we can get the answers if we interpret each part of the puzzle.
Actually, that's one of the limitations of pattern ERG, that in patients who already have very low vision, there's no point doing a pattern ERG. You can't record it.
They won't fix it. Okay, Simar, you're set.
Right. Thank you, ma'am. And thanks to AIOS Scientific Committee for giving this session. So, in testing the retina, I think we have tested the whole of the retina. We have tested the macular part, We've tested the photoreceptors. It's now time for the RPE, which is primarily tested by the electro-oculogram. So we've heard about the other tests that are listed here, which test the rest of the pathway. Electro-oculogram is a measure of the function of the RPE. So our eye is like an electric dipole, with the cornea being positive in the front and the RPE being negative at the back. And it is this difference in the voltage of between the positive and the negative side that we are trying to measure with the electro-oculogram. And how we do that is by making the eye move from one direction to the other. The positive changes to the negative and henceforth, and that difference that comes with the movement of the eye is what we record as the RPE potential, trans RPE potential, and this is a measure of the RPE function which we get with this. So just going over the technique, basically on the electrophysiology machine using a Gans field, first you get the demographics right, get the patient right, and then you select whether you are doing it in a dilated stage or an undilated. This is a test which is to be done in a dilated state, with the patient being in a room light condition for at least 30 minutes prior to the test, and you don't want to do any flash photography or indirect examination prior to doing that test. This is cleaning the skin areas where you want to put your gold cup electrodes so that your contact is proper, you have low resistance. And there are two active electrodes on the inner and the outer canthus of each eye, and the ground electrode right at the forehead. Once you have cleaned the area, you put in the active electrodes and the ground electrodes, take them away from the field of the vision of the patient so that that is not obstructed. So these are the two active electrodes for the left eye, and similarly two active electrodes, gold cup electrodes for the left eye, and you check the resistance. That should be under 5 ohms, and this is the setup that the patient has. And then you convert it into a dark room, and the patient is placed on the Gans field, and I'll just show you what the patient sees. So these are 3 lights that you can see. The red light that is there in the center changes between 15 degrees to either side of the right and left side, and you can see that red light flashing. And similarly, the patient has to be instructed to follow the red light when it is shifting, and to shift only when the light shifts. So accordingly, you are seeing the voltage potentials that are recorded each time the movement takes place, and the difference that comes once we turn on the lights of 15 minutes of dark adaptation followed by 15 minutes of light adaptation. And once the light adaptation starts, the difference in the potential starts to go up, and that is the light peak to the dark trough that we want to measure in this. So 2 steps to this. After putting in the electrodes, take the patient in dark adaptation, 15 minutes in that, and then switch on the Gans field light that is there, and that slowly the patient light adapts and the potential keeps going up, and you record that. So again, for interpretation, as we talked about, confirm the demographic details, make sure you are not doing a wrong recording. Look at the saccadic records that are present. These are displayed separately to make sure that the patient was cooperative during the examination. And improper recording may be seen in patients with poor fixation, ocular motility restriction, nystagmus, lot of photophobia, poor attention span, or if at the end of the day it's a fatigued patient who is simply not following the light. Interpretation, again, during the dark phase, the potentials will slowly go down, and between 10 to 15 minutes of your 15-minute phase, you will get the dark trough, and the light peak usually comes after starting the light phase within 7 to 12 minutes. And the ratio of the light peak to the dark trough, which was originally known as the Arden ratio but now preferred to be called as the light peak to dark trough ratio, normally should be between 1.7 to 4.3. So anything abnormal beyond that is something that we are looking to interpret in this. So just 3 cases to demonstrate how the electro-oculogram helps. This is an 8-year-old girl who presented with complaints of low vision which were detected during school screening. Vision 6/9 best corrected in both the eyes. You can see some yellowish deposits here which are present with detachment of the posterior pole. Autofluorescence helps a lot in these cases, as these vitelliform deposits kind of light up on autofluorescence. So this is indicating towards a vitelliform disorder, yes. OCT also shows you those elongated photoreceptors, shaggy photoreceptors, some focal choroidal excavation here, and a lot of deposition of this vitelliform material. So whenever you are doing the electrooculogram, it is very important to have a full field ERG which is done along with, because as we talked about, the photoreceptors are the only cells which are sensitive to light. So if your photoreceptors are not normal, your electrooculogram will be reduced. So once you have documented that your full field ERG is absolutely normal, only then you go on to interpret your electrooculogram and not otherwise. So here you can see the full field ERG because the rest of this retina was absolutely fine functioning. That is normal. And then you go on to the electrooculogram, which shows you a reduced light peak to dark trough ratio of about 1.2, and the genetics confirmed this to be a BEST1 mutation, autosomal dominant, compatible with BEST disease that we see typically in children. The second case, a little older girl, 21-year-old girl, again complains of low vision, 618 OU best corrected, and you can see here the abnormalities are a little more widespread along the arcades and a little beyond them also. And again, the electrophysiology gives you a better measure of how the abnormalities really are, and you can see this the autofluorescence gives you a better measure, and the hyper autofluorescence signal going way beyond the arcades till there. And so this picture does look like what we call as autosomal recessive bestrophinopathy, again a manifestation of BEST1 gene. The OCT looks similar with some shitic spaces along with in the retina, along with those elongated shaggy photoreceptors. Again, to confirm, you do an electrooculogram with a full field ERG. Here if you see the full field ERG, it is slightly reduced because the extent of the disorder is beyond the macula and involving the whole of the retina. So the full field ERG is slightly reduced in this, but the electrooculogram is grossly abnormal, which shows you an Arden ratio of about 0.86. And genetics confirms autosomal recessive homozygous mutation in the BEST1 gene, which confirms autosomal recessive bestrophinopathy. So where it helps more in confirming whether it is not BEST is in cases which adult onset foveomacular dystrophy. This was a 59-year-old male diagnosed as CNV elsewhere, injected with bevacizumab in both the eyes, and 636, 624 vision best correcting to about 612. And this is the picture that you have. Again, you have that vitelliform material deposited right at the posterior pole, both in the right as well as the left eye. So this is what was suspected as a choroidal neovascular membrane, and the anti-VEGF injection given. You can see the OCT is very similar with a lot of vitelliform deposits and elongated photoreceptors. And the OCTA confirmed that there was no neovascular membrane here. But when you do the EOG, that clearly shows that the EOG is absolutely normal. It had a light peak to dark trough ratio of 2.2, and this is typical for adult onset foveomacular dystrophy. So BEST1 gene spectrum is where we mostly use the electrooculogram, and it helps differentiating BEST from pattern dystrophies as well as the adult onset variant of vitelliform. Typical BEST, you would have a full field ERGs that is normal and a EOG that is abnormal. Autosomal recessive BEST and autosomal dominant ADVRIC, you would have a grossly mildly abnormal full field ERG but an abnormal EOG. And in adult onset, you would have a normal full field ERG along with a normal electrooculogram. So that way you can help and differentiate this and order targeted genetic testing. Thank you.